So first we have Dr. Sudha V. Madam for examination techniques in ocular trauma.
Thank you, KSOS, and thank you, Dr. Raghu, for giving me this opportunity. This is a very general talk. We're just starting with how to examine a patient who comes to you in casualty with ocular trauma. So the first thing that we know that when he comes to casualty, the main thing that we are supposed to look is the first aid problem. You need to look at the ABCs. But for related to ophthalmology, there are two things I would like to say. This is okay. This is seen by most of the casualty person will see it. But what we need to see, there are two things which you see. If this patient is under neurocare, please do not dilate the pupil, because that is important. Those neuro people follow up this patient based on the pupil. So do not do that. Second, if this is an unconscious patient and you need to check ocular movements, the one way to do it is doll's eye movement. Again, do not do this if the patient has a neck injury, so neck or spine injury. So these are the two important things we must keep in mind, because we just go in and examine the patient. That should not be how it is done. You have to be sure that you get clearance from the other departments before you go on to do something like this. So what are the do's that you must do? Make the patient comfortable. There is no emergency immediately that you have to go and open the eye and see it. So make the patient comfortable. Prevent any further expulsion of contents. So keep the bed rest up, head elevation. And if the patient you feel requires a general anesthesia, do not ask him to eat or drink anything right now. And of course, we do the general general OT prophylaxis of tetanus and document the medico-legal case. There should be, again, don'ts. Do not apply pressure. Please do not rush and open the eye. Do not check the intraocular pressure until you're very sure that this is not an open globe. And something else, there are a lot of tissues coming out, there will be a lot of bleeding. You will try to clean it up and try to debride the tissue. Without knowing what tissue it is, do not debride. Do not debride any lid contents. Do not debride any ciliary body projecting. Remember that most important is you have to first examine. Do not touch or manipulate the eye too much. Things like LASIK flap dislocation, don't try to remove it. You don't know what it is. Just don't try to pull it out. Don't try to pull out a foreign body which is sitting into the anterior chamber. We all know this, but it is just that when you go to the casualty and see the patient, we just try to clean it up. So that is something which we must try to prevent. Before all this, rule out bradycardia, heart block, nausea, vomiting, everything. So basically make the patient comfortable. And you have to look at the pupil, you have to look at the shallow anterior chamber. If there is a peaking of the pupil, we must suspect that there is a occult globe rupture. And the other emergency that we must know is whether there is bleeding behind the eye, which is increasing the pressures and which we may need to do a lateral canthotomy before we can completely examine. Otherwise, we will have a compression in the orbit, because the orbit is a closed entity. So the preliminary examination, even before you take the history, first thing when he comes to casualty, it is something like triaging. You need to know if you want to go into that emergency condition, you need to do anything. So you have to assess the both eye, even if the eye injury is unilateral, and document it. And prevent the active bleeding there. Again, prevent, it is just try to stop it, but don't apply too much pressure, don't do much manipulation. And of course, chemical injuries, you have to first irrigate before you do anything else. So this is the preliminary part. Then you need to classify. Now trauma is, mechanical trauma especially, is now classified so that we know what the prognosis is. And the classification is based on this. It is the type of trauma, grade of trauma, RAPD presence or absence, and zone of trauma. So the type of trauma is based on history. So we need a proper history. Grade of trauma is based on what is his presenting vision, because that is the prognosis. And the presence and absence of RAPD gives you the trauma score. And the zone of trauma gives you what is it a dangerous area. So the focused history is important. So once you've settled the patient, made him comfortable, ruled out any Valsalva problems, then you ask him the history. So you ask him the time, place, the nature, the usual history which we will ask. But more important is what is the treatment he's got before he reached us. Most often, somebody must have pulled him up from an RTA place and brought him here. So we need to know, has he placed any drops? Has he done anything before he has brought him? Maybe he's given some pressure bandage. We need to know this. Has he applied any atropine ointment? Some of them do that. So I've got a patient who had actually got atropine ointment. We didn't realize this. That was because it was not an atropine ointment. He was given an Ayurvedic drop. But inside that, there was atropine. So if you're not sure, this pupil was dilated. We were looking, what is this third nerve palsy? What is this? It's actually simple because the Ayurveda person had put a drop. And then only later we realized it. So examination, always make sure that you examine the patient in very bright light. So open lobe injuries, you have to examine only under OT. Take him to OT or at least a place where there is an anesthetic. Okay. Record the visual acuity, very, very important, without pinhole and with pinhole. And again, use a strong light. Assess the adnexa for any injuries. See if there are any foreign bodies. Ear-ophthalmos, exophthalmos, we want to know the orbital compartment syndrome. And ocular motility in all the cardinal positions of gaze and pupils for RAPD. Then come to palpation. Now don't try to palpate, put in a speculum. So make sure before first palpate the orbit and then use a lid retractor or speculum with topical anesthesia and assess the IOP. You may need to do a Siedel's test, but a little more detailed examination with slit lamp or a fundus examination you can do a little later. And a gonioscopy, you have to decide whether you want to do it emergently or not. Suppose you are thinking or there is a foreign body in the angle, you may require to do a gonioscopy. So detailed examination can be done a little more comfortably. Do you need to go for emergency imaging? Yes. When you are in casualty, sometimes if you're suspecting an optic nerve injury, they do an emergency ultrasound to see the edema. That is possible because that is immediately available. That is one reason. And of course, if your globe, you are suspecting an occult rupture, you may need to do, if you have a casualty ultrasound, at least it's not contraindicated, you can do it gently. But MRI, of course, you should, if there's an intraocular foreign body, do not do it. And urgent CT head, when do you do? When you suspect this vision is suddenly decreasing. Patient is going into, we have had cases where just a little bit of edema, but patient's vision was totally out of proportion. And what was the reason? There was a superior subperiosteal abscess, which was pressing upon the optic nerve. So it goes rapidly into PL negative vision. So there you will have to plan for a CT, emergency CT. So this is the ocular trauma score. This only gives the prognosis. All this is in the book, but these are the various sums. Ultimately you get, they are called raw points, and that's how you suspect it. So it's just basically severe injuries there. Now some special conditions, suppose the patient is unconscious, how to do a doll's eye movement, all of you should know this. All of those who have done post-graduation in casualty will know how to do it. Patient will obviously not listen to your commands. You have to move the eye, the head in all directions, and the eye should move to the opposite. There are patients who are totally unconscious. You move the eye in any direction, the eye looks absolutely straight. So that is brainstem injury. If the eyeball is not moving, you have to suspect a brainstem injury. Then third nerve palsy, if there is one-sided third nerve palsy, look for the pupil. The initial third nerve palsy would give a constricted pupil. If it is dilating, then you have to remember that this is uncal herniation. One-sided compression with uncal herniation is constriction followed by dilatation. This is a serious emergency. You have to inform the neuro people that they need to go in for surgery. Some special consideration in pediatric, of course, it's an unreliable history. Again, never force anything from the baby. The child will not cooperate ultimately after that if you do anything which is forced. So you may need to go under an examination under anesthesia. Remember, even if you pad the eye in a very small baby, you are likely to induce amblyopia. And always remember, if you see a retinal hemorrhage like this, bilateral severe retinal hemorrhage, this is most likely to be a battered baby syndrome. There is no other way you get such bad hemorrhages, both eyes. Now, how to assess a totally small baby? Either you place the head in both your hands and straddle the legs. Or you can do the same, the mother holds it like this and you sit on the opposite side and look at the baby's head. So that is one way. If they are fit enough, you can put them on the slit lamp or a handheld slit lamp. Seat comfortably. Talk to the baby. Examine the important parts first, threatening later. And remember, even a small hematoma there may be due to a roof fracture. The child's baby is quite fragile. The bone is quite fragile, and pencil scissor injuries, in small penetrating injuries may be seen. So the take-home message is treat the serious injury first, record the presenting vision, neurology observation required, do not dilate, make the patient comfortable, document all findings, and avoid excessive tissue manipulations. Thank you very much.